Well, I have 8 o'clock, and so with that, we will officially kick off this month's installment of the ASJ Next Generation Editors Journal Club. And I'd like to thank everybody for taking the time to tune in tonight. And I have no doubt that tonight is going to be another excellent installment in the ASJ Journal Club series. To introduce everybody, my name is Ryan Austin. I'm a plastic surgeon here in Toronto, Ontario, Canada, and I'm the lead of the Next Generation Editors. I'm joined by one of my fellow Next Generation Editors, Maryam Al-Zamani, who's a plastic surgeon in Oakville, Ontario, just down the road from me. And she's going to be curating and moderating our discussion tonight. So if you have any questions as things come up, as our discussants are speaking and presenting, please feel free to put your comments into the chat box, and we will try and answer and pose as many of those questions to our experts as we can. You'll also see multiple poll questions come up, so feel free to answer those as we go through the evening to try and stimulate a little bit more discussion. Tonight's article, hot off the presses, is one of our Editor's Choice articles from the July 2021 issue of the ASJ, is entitled Local Infiltration of Tranexamic Acid in Liposuction, a Single Surgeon Outcomes Analysis and Consideration for Minimizing Postoperative Donor Site Ecchymosis, as well as its accompanying commentary article. Tonight, we are joined by the lead author of this month's article, Dr. Jason Weissler. Dr. Weissler is originally from New York and went to college and medical school at George Washington University in Washington, D.C. He then completed a postgraduate research fellowship in plastic surgery at the University of Pennsylvania prior to joining the integrated plastic surgery training program at the Mayo Clinic in Rochester, Minnesota, where he is currently the chief resident. Dr. Weissler will begin his ASAP's endorsed aesthetic surgery fellowship next year with Dr. Louis Bucky in Philadelphia after his graduation. So thank you so much, Dr. Weissler, for joining us tonight and presenting your hard research work. We're also fortunate tonight to be joined by the lead author of the accompanying commentary to this month's article, Dr. Joseph Hunstad. Dr. Hunstad is an associate professor of plastic surgery at the University of North Carolina and has been in practice in Charlotte, North Carolina for over 34 years. Dr. Hunstad has worked extensively with the Aesthetic Society, not only on the board of directors, but as a traveling professor, for which he has been awarded the Klingbeil Award for Teaching Course Excellence. Dr. Hunstad also serves as a member of the ASJ editorial board and has authored over 80 peer-reviewed journal articles and 25 book chapters, as well as textbooks on aesthetic plastic surgery. It's an honor and a pleasure to have Dr. Hunstad here with us tonight to present his expertise and work with tranexamic acid. And completing our panel of experts tonight, we have Dr. James Fernau from Pittsburgh, Pennsylvania. Dr. Fernau completed his MD degree at the University of Utah before going on to complete residency programs in otolaryngology, head and neck surgery, and plastic surgery at the University of Pittsburgh. Dr. Fernau traveled to Virginia to complete a fellowship in aesthetic surgery with Dr. Richard Mladek before returning to Pittsburgh to practice. Dr. Fernau has spoken extensively on the use of tranexamic acid in aesthetic surgery and is the chairman of the Patient Safety Committee for the Aesthetic Society, as well as the recent recipient of a special award from the 2021 Aesthetic Meeting for his dedication to member and patient safety during COVID-19. I can't think of anybody better for joining us for his insight on tonight's topic. Thank you tonight for joining us, Dr. Fernau. So suffice it to say from that long introduction that we'll be able to learn a thing or two about tranexamic acid from these experts who are going to be discussing with us tonight. And with that, I will hand things over to Dr. Weissler, who will share his screen for his presentation of his research work for this month's Journal Club. Take it away, Dr. Weissler.
Well, thank you, Dr. Austin, and thanks for the nice introduction and for everybody who's joining us tonight. Again, I'm Jason Weissler, I'm plastic surgery resident at Mayo. And I'd like to thank the Aesthetic Surgery Journal and the Aesthetic Society for the opportunity to present our work tonight and for selecting our publication for an Editor's Choice video. Tonight we'll be talking about the role for infiltration of local TXA in liposuction and our experience at Mayo Clinic over the last several years. We have no disclosures. Recent data from the 2020 Aesthetic Plastic Surgery Data Bank reported that liposuction was the most commonly performed aesthetic procedure, accounting for nearly 300,000 procedures performed last year. Although fat grafting techniques continue to evolve, most of the advancements in lipofilling have historically focused on techniques to enhance viability of transfer fat. However, management of the donor site has largely been overlooked. Within surgical specialties, the sequela of intraoperative blood loss and need for blood transfusions has continued contributed to the introduction of various pharmacologic agents, such as TXA. TXA has gained increasing attention as dependable adjunct capable of reducing blood loss and transfusion rates. First introduced in 1957 for indications related to postpartum hemorrhage and hereditary bleeding disorders. More recently, and over the last several decades, the use of TXA has expanded to nearly all surgical subspecialties, including orthopedics, cardiac, trauma, and most recently, plastic surgery. To understand the value of TXA and why it's used in so many surgical disciplines, we'll briefly review its mechanism of action. First, TXA is a synthetic derivative of lysine that inhibits the conversion of plasminogen to plasmin, thereby preventing the degradation of fibrin clots and essentially stabilizing clots. It blocks plasmin-induced platelet activation to preserve platelets for clot formation. And lastly, it's been described to exert anti-inflammatory effects through its ability to block plasmin activation. All these unique properties lend itself to be an incredibly valuable adjunct in surgery, and through hundreds of publications has emerged as a safe, effective, and economical pharmacologic adjunct. It's been safely used across a wide variety of dosage and delivery modalities, but the ideal delivery route and dose is yet to be established. Nonetheless, it's available and effective in oral, topical, and IV formulations. And with regards to safety and dosing, to date, while there's no standard dose with reported doses ranging between 10 mg per kg all the way up to 100 milligrams per kilogram in both children and adults. While there's no standard dose, research looking at the pharmacokinetics of TXA has demonstrated that there's less systemic absorption with topical TXA when compared to its IV counterpart, likely because of its local effects. As our understanding of its use continues to evolve based on published data, its safety profile has more clearly been established. However, one common concern for surgeons who are hesitant to use TXA is the perceived clotting risk. Although numerous level 1 prospective randomized trials looking at thousands of patients have reported no increased incidence of VTE in both IV and topically administered TXA. Given its proven efficacy and acceptable safety profile, TXA has increasingly been integrated into various plastic surgery procedures. Interestingly, in the last several years, the number of publications in our literature has nearly doubled and will predictably continue to gain increasing attention. The multiple studies published on TXA overwhelmingly endorse its use, underscoring a unique opportunity for plastic surgeons to mitigate the effects of perioperative bleeding, reduce seromas, allow for drains to be removed earlier, and generate less bruising and swelling in our aesthetic face and body procedures. Within our division at Mayo, we've been routinely administering topically delivered TXA into breast pockets for our tissue expander reconstructions, and we found that there's less seromas and that drains have been coming out earlier. Our experience with its use in both IV and topical formulations encouraged our team to incorporate its use in 2018 for liposuction procedures. To study our outcomes, we retrospectively reviewed all patients undergoing autologous fat transfer as part of breast reconstruction between 2016 and 19 with our senior author. Those patients who had surgery prior to this date were considered historical controls for comparative purposes. In all patients, donor sites were selected preoperatively, and donor sites included the abdomen, flanks, mons, thighs, and knees. Photographs of the donor sites were taken during the first postoperative visit within the first 1 to 2 weeks following surgery. A blinded assessment of the photos was performed by a total of 10 senior plastic surgery residents and research fellows to determine the degree of postoperative donor site ecchymosis based on this scale adopted from a previous publication by Dr. Hunstad. Primary outcome measure included donor site ecchymosis, and secondarily, we looked at the incidence of hematoma, seroma, thromboembolic events, and seizures. Intraoperatively, donor sites were infiltrated with tumescent solution consisting of 500 milligrams of lidocaine, a milligram of epinephrine in a liter of lactated ringers. Conventional liposuction was performed using either 3 or 4 millimeter blunt tip cannulas, and immediately following the completion of liposuction, the 3 grams of TXA and 75 cc's of normal saline was infiltrated into the donor sites and delivered via blunt tip infiltration cannula. Postoperatively, patients were maintained in compression garments for a month. Overall, a total of 120 patients were reviewed, accounting for 60 patients in the TXA group and 60 historical controls. Demographics, BMI, comorbidities were similar amongst the groups. The groups did not differ with regards to liposuction donor site selection, and the most commonly used donor sites were the abdomen and flanks. There was no difference in the volume of tumescent solution injected, volume of lipoaspirate, or time to postoperative photograph amongst the 2 cohorts. The median bruising score of patients who received TXA was significantly lower than the patients who did not, based on the previously shown scale. No DVTs, PEs, seizures were reported. Here you can see some representative photographs of a patient who had received TXA and one who had not. Overall, we demonstrated that the local infiltration of TXA into liposuction donor sites safely reduces the risk of postoperative ecchymosis without increased risk of VTE or seizure. With regards to cost, at Mayo, 3 grams of TXA in the 75 cc's of saline costs approximately $25. And for the gram of IV TXA, the cost is around $14. To our knowledge, this is the first study demonstrating the role of locally infiltrated TXA in liposuction. Although our study was a small retrospective cohort study, we did find a statistically significant decrease in the degree of postoperative ecchymosis at the donor site. It must be recognized that there are no validated metrics for assessing donor site ecchymosis, and in light of this, the authors elected to use a modification of Dr. Hunstad's previously published scale, albeit non-validated. Given our promising results and continued clinical observation that TXA reduces bruising, there are certainly opportunities to further explore its role in larger cohorts and across other aesthetic procedures. In the future, we hope to ascertain whether or not there's a correlation between less ecchymosis and postoperative discomfort in the form of patient-reported outcomes. And as surgeons continue to report promising findings, in the future, we should be able to have head-to-head comparative analyses to determine superiority of a particular modality of administration and dose, be it topical, IV, or both. Comparable to the growing body of literature, we have similarly demonstrated impressive efficacy with the use of TXA and demonstrate its value in liposuction procedures. As we continue to incorporate its use in plastic surgery, we look forward to learning more about its application in other aesthetic procedures and encourage authors to continue investigating outcomes. On behalf of my co-authors and mentors at the Division of Plastic Surgery at Mayo Clinic, I'd like to thank the Aesthetic Society and ASJ for the opportunity to share our work. Thank you very much.
Thank you so much, Dr. Weissler. You should be commended on the study. It was excellent work. And certainly, I think that we have a lot to learn from this and carry forward. So with that, we will hand the microphone over to Dr. Hunstad, who wrote this month's commentary article for his reflections and thoughts.
Thank you very much. Yes, Jason, nice job. Well done with you and your colleagues. I'm pleased to let everyone know that Vanessa Molinar is one of our current fellows. She was a co-author with you. And one of the articles that you referenced before was Jim Zins and Andrew Kochuba. He's one of our associates in our practice. So we've got a lot of people in our program that have a TXA interest. It was about 4 years ago that one of my fellows, Clayton Cranford, I started to talk to him a little bit about TXA. And I said, what do you think about this? Think we should look into this? Well, one of the things, having a lot of body contouring procedures, a lot of abdominoplasties, we're always deathly concerned that we don't want to do anything whatsoever that could possibly increase the risk of VTE. VTE is a potentially fatal outcome, a disastrous outcome for our patients, for ourselves, for our practice, for everything. So no matter what we do, as long as if we're doing something that increases the risk of that, I don't want any part of it. But the fantastic thing about TXA, and it has been proven time and time again in multiple specialties, is TXA does not seem to increase the risk of thrombosis, which is fantastic. It is a clot stabilizer, not a clot propagator. And this beautiful distinction, I think, is critically important. When we're performing liposuction, we really need to be aware of two things. We need to look at our aspirate. We need to see what the ongoing blood loss is. But as importantly, and this is often overlooked, we need to keep in mind what is going on under the skin postoperatively, because there is an oozing, there is a blood loss that occurs that creates the ecchymosis that we see in these patients postoperatively. This study by Jason and his associates looked at that, and it was interesting that even that these two cohorts were slightly different. Number one, they noticed that the TXA group had a lot less bruising, but the TXA group also had greater amounts of aspiration. So not only were they suctioning more fat, but they're getting less bruising even in the face of that, which I think is incredibly positive. I think there's a huge, huge role going into the future for TXA. And I would include it consider including it in our tumescent fluid. So it's put on board prior to the beginning of liposuction, used concurrently in facelifting, and it's been demonstrated by Jim Zins and his group, reduced intraoperative bleeding and post-op hematoma rate. We see it with blepharoplasties, facelifts, and liposuction. Very nice improvement in ecchymosis, and it's been a very positive thing. And again, if we can do something that can reduce our intraoperative blood loss, as well as our secondary postoperative occult or hidden blood loss that occurs under the dressings, under the garments, that could be a real advance for our patients.
That's fantastic. Thank you so much. And Dr. Fernau, I would like to hand it over to you to see if you have any additional comments or thoughts based on either the article or Dr. Hunstad's discussion.
Yeah, I thought it was very well illustrated on the bruising. That's what I experienced as well. And I did want to point out in one of the patient safety columns, you guys can, what I've done is I put in protocols for everything from the face, abdomen, liposuction in all the areas. And I do the same thing with TXA. I tumesce first in all the areas, and I wait at least 10 minutes for the epinephrine to affect, and then I do my liposuction. And I'm finding the same things. I'm finding that there's decreased, the blood loss is definitely decreased. Decreased bruising is incredible. And the other thing that I've seen is that the tremendous decrease in pain in the patients. My patients take like 1 Percocet after high volume liposuction. Now I do use 6 grams of TXA. So I'll use 6 liters, and it's in my protocol. But I will have to say that I've done mass spectrometry on 20 patients, and a level of 150 micrograms is high, and might have been less than 50 in 20 consecutive patients. So I find that, you know, pretty significant, and I look forward to publishing my data on that. And I found it effective in facelifts, rhinoplasties. The one thing that I do different in rhinoplasty is I give it 1 gram intravenously pre-op, in addition to a small amount of local infiltration during the rhinoplasty. But congratulations, Dr. Weissler and Dr. Hunstad, excellent comments.
Thank you.
And so to pick up on that concept of dosing for our viewers who are here tonight, can you maybe, Dr. Fernau, go into a little bit just about the safety considerations when it comes to tranexamic acid? What should we be considering intravenously? What should we be considering when we're infiltrating? What about mixing those? What should people keep in mind when they're thinking about their cumulative dosing, or how much of this drug we're administering?
Right. You know, Dr. Rorik published a paper, and he had indicated 6 grams should be the maximum amount in 1 day. And of course, we use much less than that. We use a dose of 10, and our cardiovascular surgeons are up to 100. So in most of my liposuction cases, they're large volumes, I frequently use 6 grams of TXA. And then, you know, I think in a rhinoplasty, Baum and Guyron stopped using DDAVP, as I did, and we use TXA. And if it's, you know, $15 to $30 a vial, and the DDAVP is $900 a vial, it certainly makes sense to use that intravenously during rhinoplasty. And I will use it intravenously on my facelifts and breast augs. Now, I will not use it intravenously on the large volume liposuction or during abdominoplasty.
Brian, I have a quick comment. You know, it has yet to be fully elucidated with respect to what is the best mode of administration in all the plastic surgery procedures. We have used it IV when I haven't had it in my tumescent fluid, Jim, and it's worked. It seemingly has helped us quite a bit. We've used it direct as topical application in blepharoplasties, but now I inject it. I mean, I think these things all will be defined in the future, but it's a very exciting future because we've got an incredibly safe product that's cheap and doesn't seem to cause any problems. I mean, it's almost one of those too good to be true things, but I think there's a potential use, as I said in my commentary, in virtually all aspects of aesthetic plastic surgery going forward for TXA.
And Dr. Hunstad, do you have any concerns, as Dr. Fernau mentioned, in regards to intravenous application in these bigger body contouring surgeries, when perhaps we're thinking of Caprini's score, perhaps we're thinking of anticoagulation in the hours and days following surgery? Do you have any thoughts on that?
Yes. So just recently in ASJ, we published our review of 600 consecutive patients where we give a Xarelto postoperatively after an abdominoplasty. We don't want any risk of a hematoma. We can't fix that. We can fix everything else. So it's ironic that we'll use TXA in combination with anticoagulation. I don't think they fight each other. Again, this is a clot stabilizer, a fibrin clot, and doesn't really interfere with our anticoagulation to reduce our risk of VTE. I think they can work well together.
Yeah, I think that's a really good point, Joe. My patients that are low risk, I'll put them on a baby aspirin for 30 days. Now, people that are high risk, I'll use Xarelto as well.
And when it comes to method of administration, I know Dr. Hunstad, you were mentioning that. Do you think so? The authors in this paper with Dr. Weissler just presented, they did their tumescent, they did their liposuction, and then infiltrated the TXA. Do you think that there's a benefit to doing that as opposed to putting it in the tumescent solution and potentially aspirating out that medication so it's not sitting there quite as long? Does that make a difference, or is it kind of dealer's choice?
You know, that's a great question, and I don't think we know the answer to that. I'm interested in hearing what Jim has to say. But to me, it would make sense to put it in the tumescent fluid, and this is the reason. Number one, we know we don't suck all that fluid out. There's a lot of it left over when we're done, and that would give the TXA the longest opportunity to remain in the system and be effective. So that's I don't have anything to base it on other than that's just my perception. I'm interested in hearing what Dr. Fernau says about that.
Yeah, I agree, Joe. I'll wait 10 minutes before starting on the first area, like the flanks. And then by the time I get to the next area, say the back and bra line, it'll be 30 to 60 minutes before I start there. So I really don't think it matters. And the results are really incredible. If you guys will indulge me, I'm just going to show you a quick, now this is a 1-day post-op facelift patient, and she just had tumescent fluid in the facelift.
Or TXA in the fluid.
Post-op, in the full facelift, neck lift, and upper and lower eyelid surgery. How do you feel?
Amazing. I had no pain, and look, here's the results.
She looks great.
So that's 1 day after a major facelift, neck lift, and upper and lower blephs. And that's what I'm seeing. I'm seeing no bruising in rhinoplasties. I'm seeing no bruising in facelifts and minimal bruising in liposuction. So I think this is a very important topic, and I commend you guys.
And Dr. Weissler, a question for you. From your point of view, do we have any concerns? So, we're talking a lot about liposuction and reducing the donor site. Do we have any concerns with your paper when you're talking about fat grafting and actually taking those fat cells and trying to transfer them out and, altering, impacting the viability of those cells? Or is this medication just, gonna totally be inert and not have any impact on our fat graft take or sustainability?
Yeah, that's an excellent question. So we do the lipoaspiration and then we process the fat immediately. So we're putting the TXA in after we already removed the fat. So the fat's already being processed in the revolve system and being transferred to the breast. And so with these patients, at least in this study, we weren't putting TXA into the breast and we're just putting it into the donor site. So it shouldn't have any impact. Now, that would be another good study, at least in the future, to see, does TXA mix well with the fat transfer to the breast? I don't know. I guess it's to be seen.
And I think it was interesting, if you look at figure 2 in the paper, certainly you show a patient who had TXA afterwards and really very little donor site bruising, but significant bruising throughout the breast. So that may kind of further speak to the efficacy of the medication. I saw Dr. Hunstad shrug when I asked that question. Do you have any thoughts, or again, is this something that we just don't have the answer to at this point?
I mean, the question is, will the addition of TXA in the tumescent fluid be detrimental to the harvest and take of fat graft? I mean, who knows? I would think probably unlikely, but again, I have nothing to base that on. We need to look into that for sure.
Yeah.
I mean, think about it. If we're harvesting fat, more pure fat, less blood, less contamination, theoretically, that's a positive thing, but I'm not certain that TXA has any negative interaction. I would hope not, but I don't know.
Yeah. And to any of the authors or the discussants, have you seen or used any difference between any kind of energy-based modalities for liposuction? Does TXA work across all spectrums? If we're using ultrasound, laser, power, traditional suction, we would expect the same benefit, no? Or would that have any implication?
Well, I know that Joe uses Body Tight, and I do as well. And I think it dramatically decreases the bleeding.
Yeah, we use power, we use micro air PAO, we use a Vaser, we use Body Tight, and we also use J Plasma or whatever the other term, Apex, whatever the other term for that is. And I think across the board, it's effective.
Fantastic. Well, Dr. Zamani, I know you've been monitoring the chat box and keeping an eye on the poll questions. Maybe we'll hand over to you for what some of our attendees are getting into tonight. And I encourage anybody, if you do have any questions, please make sure you get them into the chat box so we can speak to our authors.
Thank you for that. That's been such a wonderful discussion so far. So just to reflect a little bit on our poll questions so far and where our readers stand currently, it seemed that, you know, of our readers, there's almost a three-way split in between how they use and whether they use TXA in their practice. About 30% use it routinely, 30% occasionally, and 30% do not use it at all. And some of that might change after tonight's discussion, obviously. Most of our discussants are using it in their infiltration, so much like the way that it's been described in the manuscript we've been discussing. Some use it IV, and almost very few or none use it topically or orally for that matter. And the intent for most of our users is to decrease the possibility of hematoma postoperatively, then to decrease bruising and other benefits to be seen. And most of our users, after tonight's excellent expert discussion, did indicate that they'd be interested in incorporating TXA more into their practice. So that's obviously always the intent of the journal clubs like this, is to bring the expert opinions together and hopefully help make shifts in terms of positive outcomes for patients. I'm gonna turn our attention now to some of the questions and commentaries that have been coming through the chat box. And first and foremost, I'm just going to invite Dr. Robert Singer to give us his experience and opinion, as well as it seems that he's also using TXA and is seeing really magnificent results in his facelifts. And I think that'd be really interesting for all our readers to hear.
Well, thank you for including me. I wasn't planning on commenting. An excellent discussion. I think this is one of the great advances in plastic surgery. I think I can speak with regard to the face. I've used it significantly in the face recently. And I think that the advances that I've seen, the greatest advances in facelifting, which is not the discussion here, is one, individualization and analysis of what the patient needs to achieve what you want. Secondly, I think it's fat grafting. And for me, which I've just added as a significant advance, is tranexamic acid. I think that the operative procedure is better. There's less oozing. It doesn't stop at all in a patient. Patients who have a tendency to really bruise are still going to bruise, but far less. I find it's not only less bruising, less swelling. For some reason, they feel more comfortable, which Jim said he's finding with his body contouring. I haven't used it in my suction as far as body contouring. Somebody had a question on or a chat about tumescent, and yes, they're right. Tumescent solution is not, or tumescence is not what we classically do. That was a Klein term. we use a super wet technique. I think that was defined, the difference by Peter Fedor. I have used it in breast surgery, both in lifts, reductions, and in capsulectomies. And I think it makes a significant difference in the amount of oozing that I see and the amount of drainage after. So I compliment the author, and I really compliment the discussants. I think this is excellent. And I think that everybody in plastics should be aware of the availability of this, the low cost of it, and the lack of any great problems with it. A great discussion, and a very appropriate thing for Journal Club. Thank you.
Thank you for that, Dr. Singer. The next question that has come up a bit in the chat box is really, and I think all of our authors and discussants can speak to in terms of their experience. I know Dr. Fernau alluded to his table of having different dosages for different procedures, but I think our audience, especially the ones that aren't particularly familiar with using TXA and have some of that built-in hesitancy, they'd like to know how you typically determine what amount of TXA to use, and whether there's any modifications that you do apply in patients who have higher Caprini scores or just are slightly at high risk. I know we discussed about, still using our chemoprophylaxis as needed, but do you change the dosages, or do you change how you administer your TXA in higher risk patients?
Well, I think that's an excellent question. If they're over 4, if they're high risk, moderate or high risk, I do not use TXA. How about you, Joe?
We consider all of our abdominoplasty patients high risk, and we anticoagulate everyone, and we do it postoperatively. And again, our experience has been very, very good. No problems with bleeding. In those cases, I still like the use of TXA, because again, I think the studies to date have shown that it does not increase the risk of a blood clot, of a VTE. And again, this is a clot stabilizing compound. It is not a clot propagator. And so we're using it freely in all of our abdominoplasties, all of our big body contouring procedures, and we've had a good outcome. I don't think I'm using it in a cavalier fashion, and I don't think we're taking this lightly, but we haven't seen any issues. And again, we're going there armed with the data from all of our other medical colleagues in other fields that have shown no increased risk of VTE.
Excellent. And I think, I know that Dr. Austin already alluded to this question in terms of its use in conjunction with fat grafting. Do any of our authors have any anecdotal evidence on whether using the TXA in the infiltration fluid prior to harvesting the fat, has that, to anyone's experience, affected fat viability? Do you use it, or does everyone sort of follow what was described in this paper of doing of obtaining the fat graft first and then infiltrating into the donor sites afterwards?
Well, so again, we include it in the tumescent fluid. We infiltrate with it, and I haven't seen, whether good or bad, I haven't seen any difference in outcomes. But we don't have a controlled study. It's just anecdotal in my case.
Yeah, I think that's another good question. The fat, as it's decanning, it has the TXA in it. Now, in addition, prior to my fat grafting, I'll put in about 50 cc's of the TXA solution, and I find that very helpful to decrease bruising. So the excellent presentation by Dr. Weissler, I see a much decreased bruising in those cases. Now, they're not reconstructive cases, they're breast reductions, mastopexies. So I typically will put in 250 to 500 cc's per side prior to grafting.
Excellent, thank you very much.
Fantastic. I mean, you know, I think that this has been an excellent discussion. I think this is a growing area, and I think that one that's going to get a lot more attention, certainly as we come forward. There's a lot of questions that we've asked. And one thing I'd like to ask all of our presenters tonight is, how do we measure this effectively moving forward for future studies? We saw the use of this bruising scale, which is a subjective scale in this study. Is there a great objective way that we can measure the outcomes? I know that there wasn't a score, you know, a pain score that was looked at in the study. And what other things do we need to try and look at to really get a comprehensive impact analysis of our use of what difference TXA is making when we're injecting it into a breast for a breast reduction or a mastopexy, when we're injecting it into flanks for liposuction or an abdominal flap for abdominoplasty? How do we make sure that we get this answer so that we don't kind of, you know, muddy the water with data that people question about the efficacy or the meaning of the studies or the modalities and the methods used?
Well, another great question. There was a paper in June of 2019 from Norway, and they actually measured levels, serum levels, and that's what I did in 20 consecutive patients. And levels up to 150 are considered high, and their mean, and the study from Norway was 66, and mine were all less than 50 in my 20 patients, and those were measured at 6, 12, and 24 hours. And, you know, mass spec is expensive, and I had to foot the bill myself.
Yes.
You know, Ryan, what you're asking is, can we perform a quantitative analysis on TXA versus what these studies have been? And with all due respect, Dr. Weissler, your study is very much a subjective study. It's a visual study. I get that, but that's meaningful. That's still meaningful. But the way to do a quantitative analysis, we'd almost have to do a unilateral, you know, do a bilateral case where unilaterally we've used TXA. So you've got to question the ethics of that and these other issues. I don't really know. I think it's going to be a challenge, but a numeric, quantitative, not qualitative analysis of aspirates, of you know, serum levels and other things, I think that's where we need to go to really, you know, put a handle on this, put a number on this.
Yeah, Dr. Hunstad, that's an excellent point. And there was a paper, I think a number of years ago, maybe 2018 in PRS. They used IV TXA for liposuction, and they looked actually at the volume of both the infranatant and supranatant and sort of the hematocrit in the venous blood. And I guess that's some way to measure objectively, at least through IV TXA and systemic absorption. You know, they didn't comment necessarily on postoperative ecchymosis, but I think it opened our eyes at least to less bruising or less blood loss, at least in what we aspirate. So, and you know, the mass spectroscopy, another amazing way to measure it, and it's been done. And I think we should just continue to publish these things so that we can learn more about it and how to do it safely.
Fantastic. And we've just had one last minute question come in through the chat box that I'd like to put forward regarding seroma rates. Do we think that in body contouring and facial surgery, is TXA going to impact our seroma rate and help to decrease our drain output? Dr. Hunstad, I'll throw to you.
So I don't know, but there's there's the beginning of some interest in looking at that, and there are some that have suggested that it does decrease the drainage volume and it does decrease the incidence of seroma. I don't have any personal experience with that, but it's suggested.
Dr. Fernau, any other thoughts?
Yes, I have over 200 patients, liposuction patients, and I believe the seromas are less than 5. So that's, and you know, most seromas are in the abdomen, and I do a lot of abdominal liposuction as Joe does. So I think the answer is yes. And I also use it topically in breast implant pockets and in my facelifts.
Great.
And I guess I can speak to, I guess, seromas in the breast reconstruction population. Again, I mentioned it, but we're working on publishing that data, and we did find significantly less likelihood of developing seromas. We spray, again, the 3 grams and 75 cc's into the breast pocket. The drains are coming out earlier. and patients are having less seromas. And we've been using it pretty much routinely for every case that we do here with the same dose. And I know our orthopedic colleagues are doing the same thing in total knees and seeing less blood loss and better patient-reported outcomes. So certainly a room for improvement and ongoing research.
That's fantastic. Well, with that, we have 40 minutes past the hour. We've run a little bit longer than our normal, thanks to the quality of the discussion. And I think that this is a really important topic, one that we're going to be seeing more and more of in ASJ, and certainly one we're going to be hearing more and more about at all the meetings coming up now that they're coming back online. So thank you to Dr. Weissler for presenting your study to us, for Dr. Hunstad for your thoughts and presenting your commentary, and Dr. Fernau for coming on to discuss your expertise as well in this area. Everybody make sure that you tune in next month for the Young Aesthetic Plastic Surgeons Journal Club, which is going to be the second Tuesday of the month, so the second Tuesday in August. Thank you all for tuning in tonight. Everybody have a good night, stay safe, and we will see you next month.
Nice job, Ryan and Maryam. Thank you.
Thank you.